3 colleagues who are practitioners in primary care, 3 colleagues who are leaders in primary care, and I know Onkar is also plays another interesting role recently. So I'm very grateful for your time. You probably do know what this commission is all about. Really, really appreciate your thoughts, your advice and your leadership, because primary care is one area where I think everyone in London would agree we have the best. We also have areas of significant improvement. I think in most cases we seem to know what it should look like, but the challenge is how do you make that happen? I have memories of that from 2006 with the Darzi clinics and so on and so forth. Very generous, some of my colleagues in primary care call them after me, but the polyclinic idea and what we try to achieve in getting new novel delivery models in primary care. So please give us your thoughts, and then my colleagues here, we may ask you some more specific questions. So please go ahead.
It's good to be here. It's good that we're having the commission. We haven't liaised, so we only met really for the first time. So anything could happen in the next half hour. And I hope by which time the last professor will be even more smart than he is now. So, okay. I think if we can relate back to that time, really just to say, I think the lesson to learn is it's not about organisations, it's about relationships. When it comes to improving the care that takes place inside, but particularly outside hospitals, where 90% of the activity takes place with only 7.5% of the funding, it's really important to recognise that we can only do so much in London with that limitation, but that the strengths of general practice are enduring, and general practice is but part of primary care, and primary care is but part of the whole system. But the real essence of everything is the relationship in the consultations that we have with patients, and I speak both as a doctor and as a patient, and certainly as a patient. There are times when I'm really frustrated that I can't get an appointment when I want it with my GP, who's excellent, by the way. And there are times when I really don't mind because I'm happy to let continuity do its thing. But probably the real frustration is that my GPs do not have the same level of access to community services, mental health services and diagnostic services that perhaps they might have done 10 or 15 years ago, at a time when complexity has grown. So it's not about single illnesses, it's about complex multi-morbidities going on, not just in the elderly, but in actually younger people over longer periods of time. And in the past, we would have had, surrounding our practices, really good quality community nursing services, health visitor education services, psychological services, social services engaged, and many other things that make up the whole of primary care, which enables practices and primary care to manage people outside hospitals. Those days are gone in London. We've lost the investment that was maintaining that. It's really
These are the fund-holding days you're talking about?
I'm talking about right back to the inception of the NHS.
Okay.
It's quite interesting. We could talk science or we could talk TV. And if you look at something like Call the Midwife, which is a kind of dramatisation, actually it's quite informative as to how services were run before we got good. And the difference from then to before we got good was that everything was done on a voluntary basis, and people were running around in deep deprivation. Actually, we have gone back towards some of that deprivation. So if we now look at the science, we've got a city with high mobility, multi-morbidity, and services that have been depleted. And that really is the issue, and yet we want to maintain access and continuity at a time when consultation rates have doubled in the last 5 years. That's the challenge, and I think I would say it's a holistic challenge. and we must avoid the trap of turning it into an organisational challenge.
Sure. What's the solution?
Well, I think there are a number of solutions,
Yep.
and certainly in the document I think you will have received, but we'll supply it again,
Yep.
and with further opportunities for providing evidence.
Fantastic.
This is about supporting patients in their communities
Yep.
by good quality community, general practice community, mental
Yep.
health services, integrated,
Yep.
but not integrated in, for the purpose of integration.
Yep.
Integrated in order to enable patients to be signposted
Yep.
and linked up. So it's about whole patient care. That's the solution.
Thank you. Briefly, I think,
Okay.
Onkar and then Dr. Chana. Yeah.
Right.
Yep.
All right. Of course, you started talking about 2007 when you were last produced a report on the Health for London, and since the environment has changed,
Yep.
we've lost the strategic health authority, we've lost the strategic development and monitoring services across London. We've had a top-down reorganisation which no one wanted and no one expected. We're left with 32 commissioning groups who are in new organisations still embedding themselves, and we also find ourselves in an environment where people feel overstretched. And I, as a practicing clinician, every day see the greater fragmentation of healthcare. Yet the magic word is about integration, but the walk of the NHS has been about fragmentation, where we're dividing up services, commissioning them out into smaller bits, and the journey of the patient is much more complex, it's much more broken up. And I think the real challenges which we face are about integration, but I am going to take a view different from Michelle, which I believe that you won't get this integration, and we haven't had it since 1948, because we haven't got organisational and financial incentives lined up. Until we get organisational and incentive alignment of the various players in the NHS, you will not be able to get that integration. What I'm talking about there is that hospitals, primary care, community services and social services should be integrated into one organisation, and also financially, so that the system acts in a way as to give the right care to the patient in the right environment by the right people at the lowest cost possible. Because at the moment, the system works in the way where hospitals are competing for work away from community care, and community care isn't designed to cope with the stresses it has, right? And so I think that the systems at the moment are wrong. We keep tinkering with the NHS. Governments come in and go, but all the time. But what we need is a whole system reform rather than tinkering in primary care or tinkering in hospitals or setting up of a foundation trust. So I think we need a wholesale reform of the NHS.
Thank you. Dr. Chana.
Very much. I just wanted to just give a little bit of context as to where I'm coming from, and then perhaps we could talk about solutions. So as I understand it, the task that we were asked was to kind of think about what's not working in terms of integration at the moment. And so the first thing I would say is that overtly the focus tends to be disease-oriented. So it's integration around a pathway which is a disease-oriented pathway, arguably led by specialists of care rather than actually thinking about what matters to patients, populations, families and carers. So I would want to flip that, to think about integration around a population and start thinking about what the needs of a population are, and then start to think about how we organise services based around that premise. I know it sounds pretty fairly obvious, but actually arguably that's not how things have worked over the last few years. So what that means is much more focus on prevention, planning, proactive care, thinking about well-being. I heard you talk about that before we joined in, not just focusing on the disease-oriented approaches that we're used to looking at. And clearly it's understandable why we do focus on disease orientation, because that's what we can measure. So we tend to design services around what we can measure rather than what's valuable to patients, populations, families and carers. So one of the challenges that we face is having currencies that are configured around needs of population rather than needs of arguably around specialist teams. So if we start thinking about integration around people, which is what Michelle was referring to, integration is about physical, mental health and social care integration in one bit. And then you think about our current system and think about where that happens, and that is through general practice. So it's through general practice orchestrated physical, mental and social care integration. And as Michelle was alluding, systematically we've uncoupled all the bits over the last few years which kind of promoted that way of behaving. So you mentioned fund holding. Fund holding gave some really good examples of population sizes of 20 to 30,000 patients around which services were configured around practices, including social care, mental health, etc., etc. So arguably some sort of contracting mechanism which incentivises that form of behaviour would be really helpful. I think the third thing I would say is about education, training, workforce development. The workforce that we have are trained, and forgive me, around a contractual mechanism. So it's about what the contract says rather than what's actually right for patients and populations. Our workforce are not trained around population-based healthcare. They're trained around diseases, organs and bits of system. So actually I think what we need to think about if we're looking at the future is how we develop a workforce which is configured around the population. And where does that population-based care occur? It occurs in primary care settings. So it needs a fundamental shift. The dial needs to turn from training in a hospital for a hospital to actually training for a population in the settings in which population-based healthcare is being delivered. Thank you.
That's very, very clear, and thank you for that. No one has mentioned the word commissioning. I mean, one of the logic behind some of the structural reforms is to hand more power to primary care physicians and general practice to design these things. I just wonder whether someone wants to just to touch on that, because that didn't. Yes, please, Michelle.
I've got one of my phrases. It's commissioning for general practice, i.e. commissioning for populations.
Yeah.
It doesn't happen.
Yeah.
And it doesn't happen because the commissioning process has got, with kind of great enthusiasm, has become classically gummed up by NHS structures and processes, has actually been hijacked. So the original intention of commissioning, and let's say commissioning 2010 style, as opposed to all the other incarnations of commissioning, which were equally as gummed up, is that everyone focuses on the budget and everyone focuses on the how do you maintain current services in hospitals, as opposed to commissioning for general practice. So to use Nav's flip argument, if you flip the mindset into focusing on primary care and patients out there in the community, which again, I'll say 90% of the activity takes place, then you start to look at how you can reshape and redesign services around them. But unless you do that, you can't achieve anything.
So what you're saying to me is that handing the resources to general practice has improved commissioning of services in the acute sector, but not necessarily in the primary care sector.
No, I don't believe that commissioning of services has been handed to general practice. If it was, we would have seen a huge difference. I think that's lip service being paid to the system that currently exists.
Okay, thank you. We'll start with Teresa.
Isn't that what the CCGs delivered? That GPs are in charge of the CCGs, so aren't they commissioning? And can I move on from that as well to consider the patient experience? Because whilst from a local government point of view, I see the debate thrown out on a regular basis about the acute sector taking up a lot of the money, and hear what you're saying, but isn't it a bit of a vicious circle that some people turn up to A&E or the urgent care centre because they can't get a GP appointment?
Yeah, if I rest my case. The reason people turn up to A&E is for a number of reasons, one of which is that. The other is health literacy. We don't invest in education of patients on how to use the service in a deprived, multi-migratory environment that we have, so people don't understand how to use it. We set an artificial target for A&E of 4 hours, so everyone thinks they can get seen in 4 hours for everything. It's a supply-led demand, if you like. So there are many, many factors, but what I will say is we must not think that GPs themselves are doing the commissioning. There are organisations called CCGs which have changed from the previous organisations, and there are GPs on their boards, but they are not led, and actually I don't think they should be. I think that primary care is too important to allow one particular discipline, and you wouldn't think I'd say this, to improve care for patients. I just think that we haven't delivered. If we had have delivered in CCG land, we would have made the change, the simpler changes, to support patients in their communities with better community services, rather, as Nav have said. That was not unachievable in the first, what has been in London, 2 years of CCGs.
Well, the CCGs, though, are only there for the last year, haven't they? It was only April
we've had them
last
longer
year.
Let me speak up the question
Right.
about commissioning. We think that GPs are in charge. First thing I want to realise is that 95% of GPs aren't even engaged in the process, only 5% are. Now, GP was thrust upon the primary care. You don't have to sign up to become a member of the clinical commissioning group. You are required to do so by law. I am not a signed up member of Ealing CCG. I refuse to sign the Constitution because I don't believe in it, but I am already a member of it because of legislation. The second thing you have to realise is that the GPs are there to deliver upon the financial incentives or the financial constraints that are given to them. And they are almost the scapegoats of the failures of the whole system. You know, when things go wrong in the service, the argument now is the GPs commissioned this, the GPs did this. The GPs are least empowered to do anything at all. And the argument for commissioning is that we must save money from the acute sector to make investment in the primary care sector to do better than anything else. But the acute sector is already overspending. There are no savings. You're in a vicious circle. You can't make investment in the primary care sector until you have savings from the acute sector. The acute sector is sucking up all the resources. What you need to do is a prime funding of primary care and community services, build up the capacity in the community, then you move shift services away from the hospitals. At the moment, commissioning is an impotent tool to deal with a situation which has been allowed to develop over years. Okay. So it doesn't work, and the GPs don't want to be doing it anyway in the first place.
Thank you. I think we're going to have a wonderful discussion. This is really going to be quite rich, but I just want everyone to come in. So, Andy, and then...
I think there is a commonality in the language that you're using here. I'm not sure I'd agree with you, Onkar, that we actually need more radical transformational change. I don't think there's the appetite for that, and clearly GPs do need to be much more engaged and empowered. But what you're talking about is integrating systems across secondary and primary care, and focusing on a population and considering commissioning for outcomes. And as Michelle said, a lot of that kind of integration can be achieved through relationships. So what is there to stop us doing that and moving in that direction?
So, if I may, I think that was exactly one of the things that I was going to say, was that actually what's missing from our discussion around integration is what I would call clinical integration, where colleagues across the population actually work together for outcomes. We have an incredibly transactional landscape, though. So at the moment, commissioning is very much about contracting, procurement, and competitive type approaches. It's not really about thinking about a population, how we bring providers together around a system to improve outcomes. Now, that's a very generic statement, and there are very good examples of excellent commissioning going on, but there are also some examples where actually the bureaucracy's got in the way of doing the right thing. And I think I go back to the point that actually some of our behaviours, amongst clinicians, are now so entrenched in the procurement competitive kind of engineering of the NHS that actually seeing the wood from the trees has been lost. And arguably some of the big reports last year, sort of the Francis report, Berwick report, etc., to me implied that we've lost our way in the system, that we've got more focused on the engineering rather than the outcome. And I think it would be very simple, as you say, Andy, to get clinicians aligned, but why isn't that happening? I think things get in the way, and that's called, procurement approaches and competitive kind of commissioning approaches. So I think the language that we use is important to work around.
Sorry, Michelle, you want to say something?
Absolutely. I was just going to add, and actually, again, let me emphasise how glad I am that we're having this review, because there's a tendency to compare London with the rest of the country in all the figures, which drives the kind of process. And for all the reasons you know and we know, London is different. It is more complex. The pressure is harder. Yeah. We have English not spoken as a first language. Where I live, in Brent, there are 169 languages. And of course, it would be great if everyone did speak English. And we have a middle-class system working for middle-class values, and it's not taking any note of any variation. And we're being compared against that. So the first thing I would say is we have a much higher workload in general practice and in primary care and in hospitals, and our behaviours at all levels do not conspire or even choose to work together to be able to make a difference. So we have examples of the best hospitals in London still sending out patients with no discharge summaries to their GPs, still sending out patients on a Friday night with no backup, no checking whether there's been any community services. And yes, if we had 24/7 services for everybody, then we would have all those diagnostics available 24/7 as well. So the system tends to be stretched, it's politicised, and actually it all boils down to whether we can get on with each other and communicate well with each other. And 10 years ago, maybe 20 years ago, we used to know which consultants and which specialists were in our local... Exactly. We used to know where you were, had you tagged.
Absolutely.
We no longer know who's there, when or what ever. So it's become much more unstable and fragmented.
Thank you.
And there is something about patients and respecting patients and enabling patients to be the conduit of the transmission of medical information that I think also needs to be addressed. And there's something about low-tech rather than high-tech being the thing that is driving things like telehealth, so much of which could be centred around communities, populations around their GPs.
Thank you.
I mean, it seems to me that there's a real danger of a discussion like this becoming polarised to either or, and you know, it is either population-based or acute, and it's not really like that, because actually, the better the population-based approach works, the better the acute approach works, the better the specialist services are, because people are able to focus on the delivery of high-quality patient services, and as Thomas Lee has said, you know, putting high throughput in particular areas through perhaps more focused groups. So I just wonder. I mean, I come from a different jurisdiction. I came here about 18 months ago, and I just wonder, how do you feel and the commissioning process actually contributes to or mitigates against the delivery of that sort of an integrated delivery of care?
Well, one of the course things is to recognise that the systems that exist at the moment have failed to give that integration around the patient care. Consultants and GPs do talk occasionally about the pathways, but there are some contractual arrangements which come in the way, and I think we've been alluded to that the system works in a way that there's hospital acute sector, there's primary care, there's community services, and there's social services, and somehow the incentives aren't all aligned up so that the care can be given to the patient in the right environment. So I think that we need to start looking at an integration, not in terms of organisation, but also in terms of finance flows, so that hospitals will feel it in the incentives to discharge a patient to the community and make sure those services are in place, and to avoid readmission of this patient. Because we know, for example, in London, and this data are available already, that 28-day readmissions in London have gone up. And that is because, right, either they're being discharged prematurely, or that the systems are not existing in the community to keep them in the community. And that's why it's gone up. So I think until we have a system where the hospital knows that we're discharging this patient into a system which can look after them, and that will really need alignment of financial incentive and organizational incentive. I think we're all saying the same language. But I think where we failed so far is that we've set up more boundaries in the whole system rather than integrating them. And the incentives, which I'm talking about financial incentives, are such that they don't help each other.
May I just follow on from that, just very briefly? I mean, I think in a population-based healthcare system, it is mandated that acute care is of high quality as well as preventative, proactive care. And I think what we're saying is that arguably the way that we commission is very much focused around acute care services, because arguably they're the most expensive in the way that we think things through. But actually what's missing for me is health and social care integration at the moment. So where clinical commissioning works really well is where, in spite of the current policy, health and social care integration is taking place. So where we want to move to, I hope, is health and social care integration in its true sense. So we think about joint funding and think about incentives that make the right thing happen. And that's important because, as I said earlier, we have a national illness service. We don't have a national health and well-being service. Health and well-being are really important components of a future healthcare model that we have. So the way that we support people to look after themselves better, the way we think think about preventing illness in the first place needs huge, in my view, social care input as well, and we don't necessarily see that in the way that we commission at the moment.
Thank you. Nick?
Could I sort of just highlight the extent to which there's a real conflict in the evidence that we're hearing? We're hearing all the frustrations, and you've expressed it incredibly well, about some of the difficulties of trying to make the integration that you all feel is necessary work in practice. But your focus is very much on trying to do the right thing by population rather than focusing more narrowly on disease. But the other end of the spectrum, and we heard it very obviously from two of our witnesses, including the last one, Dr. Lee, was when there is a focus on disease, the stroke initiative, it produces demonstrably positive outcomes. So in our position, would you be guided by that evidence base that says things like that work, do that, or would you follow the more theoretical position that I think all of you have really expressed to us this morning about it's right to have a better integrated service that really focuses on the individual and the population?
They're not conflicted. So, I mean, I think we're sitting here kind of polarising to make the point, but of course it's really complicated. However, you know, not every disease is a multi-faceted disease. People have strokes, people can be prevented. So I think the system needs to be able to work with both. And at the moment it is polarised. That's the problem. So if you are looking to integrate, you might not want to integrate everything all at once. You know, we always fall into the temptation of going for the big bang picture. Incremental integration is okay. And it may be that we need to start in the communities and work out towards hospitals, and obviously there will be all steps in between, rather than trying to integrate everything all at once. We can't afford integration all at once. We can't afford the infrastructure, but we can afford to create facts on the ground on certain areas. And I think you would be... it would be wrong to think that I certainly was sitting here saying no, hospitals shouldn't be funded and single diseases or even by-track diseases. It's about multiple mechanisms.
That's very useful, thank you. Could I just come back and say, I don't think it's in the remit of this commission to change structures, okay? So what I'm interested in finding out is, within the current structure, what could you advise us to do to really drive the quality improvements that we are aspiring to do? I think our aspirations in this room, there's no question about it, all united. How do we get there? Structural change doesn't yield anything. I mean, I just say all sorts of governments have done structural change. The second thing, before you go, I'd like to get your views, as we're going to hear at some stage about integrated care providers, and there's one in Northwest London. And what's your thoughts and views about that being external? I suspect you nothing to do with Northwest London, am I correct? Or
no, we're both.
You are both. Yeah, that's right. Ealing, absolutely. Yeah, is it Ealing Town? Yeah. So I just wonder what your thoughts are in relation to that. What's working? Any thoughts about that?
Well, first of all,
maybe you want. Yeah. Whatever.
Yeah. I mean, if I just start, I'll say that I think, given the structure where we are, right, but I think one thing is becoming very apparent is that we need a strategic leadership in London.
Okay.
And that we need someone to fulfill the vacuum, to look for planning across London. That's been recognised in even the King's Fund when they talk about lack of strategic leadership across London. So I think that's one thing we can do. And I think we need to somehow enable more investment to take place in primary care and community services, that we do need to build that capacity up so that we can go for the reforms and challenges that are facing the NHS.
Is it structural? Is it human capital? What is it?
I think it requires human capital, and it needs infrastructure development.
Okay.
To provide the services, and also we need to people who are trained to give the services in the community which we want them to give.
Yeah.
And we're shifting staff, nurses and doctors and other workers from the hospital environment to the community. There are different educational needs and different sort of human resources requirements, and so education and training is important. And the third thing is that, of course, the whole systems of how we can set up incentives, right, in the commissioning arrangements, that the organisations work much more efficiently.
Okay. Thank you.
May I just,
one other thought?
Just follow on what can we do now. I completely agree that further sort of structural reform is probably going to be very difficult. But I think we have enough within the existing system in order to redesign things. So the first thing I would say is that we need to promote collaborative networks. So this is not just vertically across the system between primary and secondary care, but also horizontally. So general practice, pharmacy, dental optometry, social care, much more working horizontally across the system around the needs of a population. I think we need to align things. So we have healthcare resources, there's education training resources, there's health innovation resources, there's academic and research resources. I think we should align them across the population and start thinking about where there's convergence, and then we make sure that we use that investment to make the right thing happen.
Is the Academic Health Sciences Network doing any of that in your patch?
Yeah, well, we are, but again, people think of these things very separately. So that's about sort of research and innovation rather. And just the third thing I would say is the focus on well-being. In all the assets, arguably, that we need to design our healthcare system sit in our communities. They're called patients, third sector groups, voluntary organisations. We've got to think about how we harness those so we actually use them to make a difference rather than actually do things unto them.
Well, your thought on that are very, very, very relevant here. One of Mayor's powers, the executive powers, is the health and well-being. So we really want to look at that. We have a full session on that next week. If you have any... I know you've done submissions, Michelle. I haven't seen it. I'm just waiting for the... If you can, it will be wonderful. And one last thing, I'm not sure whether it's covered in your submission or not. There's, everyone says, and there's the evidence-based support, there's a variation in the quality of primary care. What I'd like to know is how do we tackle poor performance in primary care in London? You are the leaders, and, it's you who need to deal with this. And what do you need to empower peer pressure in dealing with quality issues in primary care? And so it would be great if you have any thoughts about that privately. You want to share it with me or send me some notes. Would be very
grateful. We'll address that in our next submission.
Is that okay?
Yeah.
We're running out of time. I'd love to spend all afternoon here. And thank you very, very much for coming. I know you have all busy practices. Thank you for being here. Lovely to see you all again. And thanks again for being here. Thank you.